welcome everyone again. This is a seminar that's conducted to talk about kidney disease and treatment options. And so the way we are going to work today is that we would have a story of a recipient, and he's going to speak about 5 minutes. His name is Nick Mutta. He's, I believe he got his kidney transplant done sometime in 2004, 2005, approximately. He will talk more about it. After that, we will have Dr. Sumeet Suneja, the presentation. It will be quite in-depth presentation. I had an opportunity to take a peek at the presentation. It's a wonderful presentation. It will be really helpful for us as a staff, but also for our clients as well, because we see vulnerable population as well. And then Dr. Sumeet Suneja will invite also Dr. Istvan to talk about it. And then after that, once the presentation is completed, we will have an open question and answer session. Please be generous with your questions, because today is an opportunity to get to know about this kidney disease. And Dr. Sumeet Suneja and both Istvan will talk about how the South Asian community has a higher rate of kidney disease, why it is, what can we do about to prevent it. So I'm going to, Nick, if you can introduce yourself. You have about 5 minutes to quickly give your version, how you felt, how did it all come about, and what was your experience within our healthcare system, and how you are taking care of your kidneys now. So it will be awesome if we can hear from you, and then Dr. Sumeet Suneja will present her presentation along with Dr. Istvan as well. So go ahead, Nick.
My name is Nick Mutta. I am a kidney transplant recipient. My transplantation happened in 2005. I was on this for about 2.5 years while we waited for the process. My mom is my donor, so she gave me birth twice. That's how I like to phrase it. It's been a very long, tedious, self-realizing journey. I think it's been something that has required me to really take charge, take control, and really the onus is on me and how far I'm willing to go and what I'm willing to accept. And so what I would start with always when I talk about my transplant is my story. And my story is that I was 27 years old. I used to play 3 pickup soccer games a week. I was delivering beer kegs at the time, 70 kilos, about 150 kegs a day. I was probably around 200 pounds, and I was working out. I was as active as could possibly be. I married a 1.5 years, building my recording studio in the basement. And then one day it just felt like I couldn't breathe. And slowly, I tried different things through the course of the day. And then, it was winter time, so, didn't really want to go outside. So I just kind of trying to do some things around deep breathing, meditating, sitting in front of the fireplace. I remember still soaking in the tub. And for all intents and purposes, for me, I felt fine. I felt normal. And then towards some point around 10 p.m., 11 p.m., that's when I went to my wife and I said, something doesn't feel right. Let's go check my blood pressure. So we went to a local Shoppers Drug Mart late at night. I think this is probably like 10 p.m., 11 p.m. We're in a rural area almost. There's no one there except the Shoppers and the Metro. So I remember putting my arm in and there was no readings that were coming out on those digital meters. And then so I was like, okay, that's, in my head, I was like, okay, that's kind of weird. Let me try it again. I try it, no numbers again. And then the pharmacist wasn't there. Nobody's really there in the store. So like, okay, you know what? I got back in the car and told my wife to drive and let's go to Georgetown Hospital. From that, what I really remember is I remember maybe parts of the drive there. I remember lots of snow. I remember uphill, downhill, a lot of grinding gears late at night. I get there. I remember walking into the ER. I remember just going to the nurse that was at the station, and she's like, hey dear, how can I help you? I can't breathe, I'm having difficulty catching a breath. Okay, no problem, have a seat. So she takes my blood pressure, takes my vitals, and she's so nonchalant, and it didn't even raise any alarms to me. And then I remember she's like, okay, dear, have a seat. The doctor will be with you in a second, or however long it's going to take. And so I remember just walking maybe 15 feet, and I didn't even get a chance to sit down. And it started with, I remember getting up from that chair with the nurse, looking at the meter and saying, oh, those numbers look kind of weird. Heart rate 190 and 250 over 190. It's like, oh, yeah, that seems kind of weird, but she's not worried, so I'm not worried. So anyways, I go to the seat. Before I could even sit down, this doctor just came running from behind some curtain or something. He just grabbed me, put his arm around my shoulder like this. All right, sir, come with me, Mr. Mutta. And then we just walked, and he's, do you know what's happening? I'm like, nope, I don't know what's going on. And then basically they gave me nitro. And from that point on, I don't remember anything. And then I woke up, and then I was just told, do you know why you're here? I'm like, no. I go, can you get me up so I can go and play my soccer game, right? So the doctor is like, no, sir, you're not going anywhere. You've had kidney failure, right? And so this was foreign. It was new. I mean, when I was on dialysis, I was the young guy there. There was no one else there. Everyone was in their 50s, 60s, 70s. And I'm this guy walking in his 20s getting dialysis back in 2002. Everywhere I went, I was the young guy. And everyone's like, what happened to you? Why are you here, right? And so I think that journey itself on why it happened, I think I've kind of lost track with that. I'm not really concerned with that more so anymore. I think it would be really nice to still know. I think there's a lot of research that needs to happen around there. But in general, I found that it's something that I take health very passionately. I am in control of my health. I may not like where it's headed sometimes. I may not like the numbers that I see sometimes, but I know that I'm in control and I get to choose that destiny. And it's a constant work in progress. It's a constant reminder that to be patient, self-care, and it's the process that I think I'm still kind of unfolding with every day. It is not easy. I like to say that I think the analogy I heard a long time ago was it's like boiling a frog. You don't put a frog in boiling hot water. You put them in slow water, cold, slow water, and you bring it up slowly, and then they don't know that they're boiling. And that's really what kidney failure to me is that it's something that's so gradual, you don't even realize it's happening. And all of a sudden, one day you're in a hospital and you're getting this out of your thigh or your neck. So definitely, I think it's something that we don't take seriously because it's something that we don't see. Most people don't really know anything about kidney disease unless they have diabetes or they have someone in their family that's had some kind of kidney disease. When I was on dialysis, there was no one around me in my immediate circle. Even now, there's still no one in my immediate circle that has had it. I've met a lot of people who are on dialysis and I've had transplants through the Transplant Society and through the transplant games. But really, I still haven't met anyone directly in my immediate circles. But I know that there's hundreds and hundreds of people on dialysis and hundreds of people with transplantations. So it is something that is always on the forefront of my mind, especially when it comes to healthcare and comes to choices. And that's something that I'm really passionate about. So I hope that that kind of gives a good idea of kind of my thought process where I'm at and transplantation and organ donation. I think that's all very important. Everything, it's all overlooked, again, because it's something that we don't really see. It affects a very small amount of people. We need to really investigate, push forward, look into, and really get some more answers.
Thank you, Yadav, for sharing with me your journey and sharing with everyone. That's so wonderful. And if you can stay, that would be awesome. But I understand that you are in the middle of your course, and if you have to log off, we all thank you for sharing your story. And Paula and I will connect with you later on. Okay.
Any questions you can always forward through yourself than anyone else as well. No
okay.
problem.
Okay. Thank you, Vete. Thank you. Now, I would like to introduce Dr. Sumeet Suneja. She is a medical doctor I will let her introduce because I am really not good with the medical terms. So I'm going to let Dr. Suneja introduce herself and her specialty. And over to you, Dr. Sumeet.
Thank you, Baldev. Thank you, everyone, for joining us today. I'm Suneja. I'm one of the nephrologists. I work at William Osler Health System, and I also do some transplant work at St. Michael's Hospital downtown. And thank you so much, Nick, for sharing such a personal and touching story. And patients like you and donors like your mom just continue to inspire us as physicians. And we're so impressed with people. Like, I've seen so many patients go through this journey like you described. And we feel so impressed with people who come forward as kidney donors. It truly is the most astonishing, selfless act. And it's like you said, like you gave you birth twice. So, it cannot be more true. And truly setting an incredible example of love and care for others. And as a nephrologist, we deal with patients, like our relationship with patients is so personal. And it starts off early in early stages of kidney disease. And we follow them for years, trying to prevent their disease progression and get to know their lives, their families. And as their disease progresses and they get to advanced kidney disease, to kind of deal with great psychological stress that they go through and help them navigate and preparing for dialysis and transplant. It's a very, very fulfilling journey, and I would not do anything in my life other than being a nephrologist. And we feel very passionate about helping people with kidney disease to live their best life possible. So I wish you very good luck, Nick, and thanks again. So moving on to our objectives for today. So we're going to go through the function of patients who are of South Asian descent at much higher risk of kidney disease. And how is kidney failure treated, and some of the cultural barriers we see in South Asian community with regard to kidney transplant. So in terms of function of kidneys, so as you know, we have two kidneys. They actually sit at the back near your spine, and they weigh about the size of your fist. My fist is small, but a bit bigger. So 150 grams. So kidney size is only about 150 grams, but it's a mighty organ that's so vital for your health. And kidney works every minute of the day to filter your blood and excrete all the waste and extra water. Urine flows through kidneys into these pipes, two tubes of muscle called ureters, and these attach to the bladder as it's shown in the diagram. And that's how the urine comes out. The kidneys will get rid of the extra acid that's produced by the cells in our body, and all the protein that we eat is converted into acid. So the kidneys get rid of that and maintain an ideal pH, which is important for optimal functioning. It maintains a very healthy balance of salt, water, minerals such as sodium, calcium, phosphorus, and potassium in your blood. And that's very important, to have these ideal levels to function properly for your brain, for your heart, and overall well-being. Kidneys are very important to excrete the drugs we take. So that's why it's very important to make sure that anyone with kidney disease, the medication doses need to be adjusted for the drugs that are excreted by the kidneys. So not only kidney does all of that, it also has a lot of endocrine functions. So which means that it produces hormones. It regulates our blood pressure by a hormone called renin. And it also produces a hormone called erythropoietin, which is basically a signal to the bone marrow to make red blood cells. So when kidneys don't work, we need to give this via an injection called Eprex or Aranesp, and it is given to patients so that the red blood cells are made. Otherwise, they get very anemic and feel tired. The kidney also activates vitamin D. So the vitamin D in the body is activated in the kidney, and that helps keeps our bones strong and healthy. So our brilliant kidneys, I'm a biased nephrologist. I think kidneys are the most brilliant organs in the body and the most hardworking one, getting 25% of the blood from every heartbeat that comes along. And okay, the brain might be a little more brilliant than the kidneys, but I'll leave it at that. So the kidneys get about 180 liters of blood a day. So they're filtering 180 liters of fluid, and 99% of that is being absorbed back into the bloodstream, and 1%, which is 2 liters, becomes urine. So that's a daily task. And so that's how it kind of filters the blood. It also acts like a sieve or a strainer. So a normal kidney does not leak any blood or protein in the urine. So when we see urine test showing any blood or protein, that's abnormal, and that needs further investigation. 1 nephron is the basic functional unit of the kidney. So there are 1 million nephrons in the kidney, in each kidney, And that's how we get our name. We specialize in nephrons, so we're nephrologists. So the kidney has a very, very complex role in our bodies to keep us healthy. So what is kidney disease? So it is damage, gradual damage, like Nick mentioned, reflected by decrease in glomerular filtration rate. So the GFR is basically glomerular filtration rate, and that's measured by a special equation using the blood creatinine level. And we also check urinalysis for blood and protein. So there are 5 stages of kidney disease. Stage 1 and 2, so patients who have GFR or the eGFR, the filtration rate, 60 and over, you have to have some other problem. So any structural damage in the kidney or any blood or protein in the urine. So that becomes significant, and they're labeled as stage 1 or 2 kidney disease based on the filtration rate. Once the filtration rate falls less than 60, that's cause of concern. You're already falling into stage 3 kidney disease. So from 30 to about 60, you're at stage 3. When you get down to 15 to 29, you're at stage 4. And then when you get down to less than 15, that's stage 5 kidney disease. And that's when you're getting ready for dialysis. So interestingly, patients have no symptoms. So kidney disease in and of itself is asymptomatic until they get down to the last stage, like Nick had. Right? So it's very alarming. Like sometimes people are sitting in my office and they have their kidney function is like 20%, and they feel fine. Like, why am I here? They feel well. So blood work is the key to know how well your kidneys are functioning. So in terms of the prognosis, so one of the most important things to know is the level of protein in patients' urine. So if the protein in the urine is high, it's much higher risk for disease progression. So protein is measured by something called albumin creatinine ratio, or UACR, and that's just a normal urine test, and that quantifies how much protein a patient is leaking. So if the ACR is less than 3, as you see in the first right here, if it's less than 3, and so that's no proteinuria, and those patients have much lower risk for progression. As the protein in the urine increases, if the ratio becomes over 300, then you're much higher risk for progression. So even if people have function of say 45 to 59%, and they have high protein in their urine, they are much higher risk for progression. So what is the scope of the problem? So 1 in 10 patients, 1 in 10 Canadians have chronic kidney disease. That's 4 million people in Canada. And surprisingly, 90% of the patients don't even know that they have kidney disease, and it's just progressing. Over the past 20 years, this number has tripled, right? So we're seeing a lot more kidney failure. And each day, 15 people are told that their kidneys have failed. Currently, we have about 50,000 Canadians being treated for kidney failure, and out of which 57.5% are on dialysis and 42.5% have a functioning trend. Leading cause of kidney disease is diabetes. So in Brampton, in my dialysis, 50% of my patients sitting on that chair are diabetic. So, and it's sad because diabetes can be well controlled, right? If you're taking care of yourself, taking care of your health, you control the glycemic control, and you have good glycemic control, then the disease will not progress. And there's a lot of other things that can be done this day and age to prevent disease progression. And it's very costing to our healthcare system. So average cost of dialysis per patient per year is $70,000 per year. And over 5 years, it's $350,000. And for a transplant, the first year cost for a kidney transplant is $100,000. So it's a huge burden on our healthcare system, and it really kind of stresses the need for investigations early on in preventing kidney disease and educating people as we are doing today, please. So in terms of risk factors for kidney disease, like we mentioned, the most important one is diabetes. We're also seeing an epidemic of obesity, right? So a lot of unhealthy dietary habits, kidney disease in the family, like polycystic kidney disease, or some genetic diseases that can cause kidney problems. And then heart disease, the heart and kidney go hand in hand. So people who have heart disease, they are also at much higher risk of kidney disease. People who have uncontrolled blood pressure is the second most important cause of kidney disease. Ending up on dialysis, the small arteries in the kidneys get damaged when the blood pressure is high. And people who smoke are also at high risk. Studies show that there is 40% high risk of disease progression if people who smoke versus non-smokers. So in terms of the causes, like we discussed, leading cause diabetes and blood pressure, and then there's other causes like glomerulonephritis, which basically means that there's inflammation in the kidney from other diseases. There's autoimmune disease such as lupus, vasculitis, hepatitis. So there are a lot of other categories that fall into this place. Chronic kidney disease in South Asians actually find kidney disease to be early and aggressive. So, we think that we used to think that kidney disease affects only older people, but more and more we're seeing that 46% of people who are being treated for kidney failure are actually younger than 65. And that's a huge loss of income for the working population. So, and diabetes is really increasing, especially in Brampton. We see high prevalence of diabetes, blood pressure, insulin resistant states, early coronary artery disease. All of that predisposes the South Asian patient to CKD. And almost 1 in 2 or 1 in 3 patients who have diabetes will develop chronic kidney disease. And South Asians also have 2 to 4-fold higher prevalence of diabetes than other racial groups. And they progress faster. So once they do have kidney disease, their kidney disease is progressing much faster compared to their Caucasian counterpart. They also have a higher mortality rate after renal transplantation. And it's interesting to see that end-stage renal disease a lot of times is not the problem. A lot of people with diabetes and chronic kidney disease don't even make to dialysis. They die of heart disease. So you see that reflected in the high mortality rate even after kidney transplantation. And this picture on the sides shows you how epidemic of diabetes is becoming a pandemic, more important than COVID. And India leads global top 10. So India is really coming at the forefront here. Okay, so this slide shows a study that was published in Diabetes Care showing that patients who are South Asian diabetic patients compared them to Dutch European patients. So these patients who do have a bit of proteinuria do progress much faster into something called macroalbuminuria, which is heavier proteinuria compared to their European counterparts. So that is ultimately leading to a high risk of end-stage kidney disease. And this is like just to show you that we're going to be getting a huge number of immigrants to come in the next 5 years as per the new plan. And South Asians are 7.5% of Canadian population, mostly centered in BC and Ontario. So we're seeing a whole lot of South Asians coming in, and this will be an explosion if we continue to go this route in terms of having high rates of diabetes. So it'll be an explosion in terms of having kidney disease and dealing with this in future. So what are symptoms of CKD? So as we discussed, there's no outward symptoms. Sometimes people can have foamy urine if they have protein in their urine, or they can have dark urine if they have blood in the urine. Other symptoms can come from their systemic disease. So if they have lupus affecting their kidney, they have symptoms from their systemic disease. But like I mentioned, kidney disease in and of itself may not have many symptoms until you get to the very end. And after they get to the very end, they get a function of less than 15%. They get uremic symptoms, we call, which basically means there's a lot of toxins build up in the blood and people start to lose their appetite. They feel nauseous. They want to throw up. There's fluid build up in the body, so they get short of breath, especially when they lie down. That's an indication that there may be fluid in the lungs. They get swelling in their ankles. Their blood pressure becomes very difficult to control. They get itchy skin, and they can get dangerous levels of potassium or a lack of. They don't get rid of acid, so the bicarbonate level falls down. So the blood work shows quite a few abnormalities indicating that they need to start kidney replacement therapy in form of transplant or dialysis. So once patients do get to stage 5 chronic kidney disease, they get, we usually follow them in our clinic in the office, and then they are transitioned to MCKC or multi-care kidney clinic. And that's a very multidisciplinary clinic where we have a whole team looking after these patients because their treatment becomes complex. So there's a dietitian, there's a pharmacist, there's a social worker helping them through this psychological stress and, advancing into starting renal replacement. They get educated about different forms of dialysis. So there is home-based therapies, which is peritoneal dialysis and home hemodialysis. So in hemodialysis, the blood is taken out from the body and it goes through a machine. It's cleaned via the machine through a filter, and then it's given back to the patient. For this blood to be taken out, this can be done. We need an access, which can be a fistula or a graft that's placed in a patient's arm. So basically that's a connection between an artery and a vein. So that's how we access the blood that is needled, and that's how the blood gets out of the body and goes into the machine. The peritoneal dialysis is more gentle. So if you imagine all your organs in one big sac in the abdomen, we use the lining of the sac called the peritoneum. And the peritoneum acts as your body's own natural filter. So what we do is we attach a catheter that goes to the skin and muscle and sits outside that sac. And then there is a machine that puts sugar-based fluid into the abdomen, and that bathes the sac and then drains the toxins out while the patient is sleeping. So this treatment is done every night while the patient is sleeping, and then during the day, they are free to do what they want. So patients can do peritoneal dialysis, which is a bit more simple. Patients can do home hemo, which is a bit complex, and in general, it's very effective. And then if all else fails, then there is in-center hemodialysis. Transplant, however, is the best treatment for kidney failure. And we are encouraging preemptive transplantation, which is the best prognosis in terms of treatment of kidney disease. Preemptive transplantation means they never even start dialysis, and they do transplant before they even get to that stage. And then transplantation, Dr. Istvan is going to go into more detail in that, but I'll go over some of the advantages of home-based therapies. So in terms of advantages, so in peritoneal dialysis, there is no blood involved, there is no needles. So patients who don't like any blood needles, they're better suited for this therapy. They can do it in the comfort of their own home. It preserves their residual kidney function. So whatever urine they're making, it stays for a lot longer, because with hemodialysis, when the blood is taken out of the body, the blood pressure drops, and then slowly the kidney kind of gets dry and people stop making urine. So one of the big advantages is their, residual kidney function, and which is very important. Even 200 mils of kidney function or urine output is, called liquid gold by one of my teachers. It's so important for their well-being. So even that 200 mils. In terms of home hemodialysis, so that it really allows to liberalize the diet. It works very effectively. Patients are not taking a lot of blood pressure medications, or, we use other medications to bind the phosphorus in the gut. They're not on those. And then the mortality is lower compared to in-center hemodialysis. And these patients with peritoneal dialysis, there's ease for travel as well. A lot of patients go to India, and, the PD company, the Baxter, they will deliver the dialysis solutions there, and they'll do their dialysis there. And so it really allows for travel and patient autonomy. So it's really wonderful. And no transportation issues to the dialysis unit. It's a snowy day. People are happy being at home, especially in COVID. We found that people who were on home-based therapies did really well. Less exposure. We had so many outbreaks in the dialysis unit. So these patients fared really well with much less risk of COVID. So transplant is the ideal treatment. So the kidney is removed from one person and given to the other, and it's the best treatment and is life-saving. And I'll let Dr. Mucsi go over that in more detail. I am going to talk to you about more on cultural barriers, especially working in Brampton, that we face in terms of transplantation. So it's so interesting to see that South Asian patients are 30% less likely to receive a kidney transplant than Caucasian patients, and 52% less likely than white patients to have an offer of living donation, and 69% less likely to have preemptive transplantation. So, why the differences in a country with such uniform access to transplantation? So this has been looked into. It's a lot of misconceptions. So there was a study that examined different cultural groups, and it was interesting to see that for patients who were Muslims, they demonstrated significantly less favorable attitudes to organ donation than their South Asian, Sikh, and Hindu contemporaries. There was uncertainty about the permissibility of organ donation in Islam. And again, religious guidance, there were negative attitudes towards donation, and also a lot of interference from the family, and local mosque or imam is very influential, as you know, in Muslim culture. And then also this sense of, that they want to maintain bodily integrity at the time of death is also important to Muslims. So it's hard for them to, sign up for kidney donation. So it's interesting to see what different factors play a role in this study. So in terms of the study showing with Hindu and Sikh religions, again, they believe in reincarnation of the soul. So there was no religious requirement for the body to remain intact after death. But still, despite, all the things we do not see a lot of patients signing their organ donor cards. And the Sikhs do emphasis on need to, put others over themselves, so more selflessness or seva, that's called in Punjabi. And that can arguably used to be promoting donation in this community. There's a lot of family influence, right? So a lot of patients who don't want to take kidneys from their kids, they don't want to burden them, or even elders, they don't want to take it from their children either. So, and in general dislike there is in the community about communicating about death or organ donation. So, I've had a lot of personal stories. I've had a patient who just recently came from India and got married here, and so young, so came up in Brampton Hospital diagnosed with end-stage kidney disease, exactly the same story that Nick described, sudden presentation, end-stage presentation, and then had to start dialysis. This is 6 months into her marriage. And so, you could see how the mother-in-law is getting so upset. And we're talking about transplant and donation, and her husband wanted to come forward as a donor, and it just freaked the mother-in-law out completely. And she was blaming her for not sharing this before the marriage. And so it was just like an Indian soap opera. It was just so sad to see this young woman go through so much, having lost her family, moving to a new country, and now diagnosed with kidney disease and having to go all of that. So there's a lot of misconceptions out there. So in terms of the story that I just described, lack of knowledge and awareness, like we discussed, and then there's also language barriers. There's a huge Punjabi and Hindi or Urdu speaking population that we need to kind of eliminate language barriers to raise awareness and provide them with culture concordant kidney transplant information. And then how do you address or how do you talk to your family about kidney donation, right? So that's also very hard for patients to do. There's always an unwillingness to talk about it. And there's also the donor pool in South Asians is less because there is high burden of chronic disease in the donors themselves who are family members who have diabetes and hypertension, and that reduces the donor pool in the South Asian community. And then there are economic constraints, less flexibility to leave work for extensive transplant workup because donors are screened very rigorously and they have to go through a whole bunch of testing. So how do we address inequities? And we're trying to we're trying to provide transplant education, which is really very important and critical in terms of alleviating misconceptions and educating them about the transplant process. And we're trying to do some media education interventions and providing education sessions to improve attitudes about living donation, and also encouraging religious organizations to help form community focus groups that can raise awareness of kidney transplantation. And finally, it has to come from the family. So we need to focus on educating families, and these are the most important influence in South Asian homes. So I will pass it on to Istvan, and he'll take over and tell us all about transplant and journey beyond. Thank you very much.
Good afternoon, everybody. Thank you for your time and interest in this topic. I'm Istvan Mucsi. I'm a transplant nephrologist. I'm working at the Toronto General Hospital at the Ejmero Transplant Center. I had been doing general nephrology before, but for the last 12 years, 13 years, I have been primarily or exclusively working with patients who wanted a kidney transplant or patients who had a kidney transplant, and I'm following them after they transplant. In my section of this discussion, I will briefly talk about living donor transplant and also the benefits of transplant compared to staying on dialysis, the process of how to get to transplant. We'll mention deceased organ donation and briefly talk about the life after transplant. I will not get into any details as we go. I will want to leave time for questions, so I just basically point to some of the topics, and then questions can come back to these later. So as we discussed, sometimes kidney disease is very sudden and abrupt, as in Nick's case, but sometimes it progresses over times, and as this story about the boiling a frog said. So when the kidney function gets down to 15%, then you need kidney replacement therapy, or at least you need to think about it, and this could be either a transplant or staying dialysis. As Dr. Suneja mentioned, transplant is a surgery, so many people don't like surgery or afraid of surgery. And so it's important to then think about, why would you want a transplant? Why would you want to go to do a surgery as opposed to just doing a medical treatment? And there's a lot of reasons there. This slide, which we will share afterwards, lists the most important differences and importance of transplant as opposed to dialysis, as it gives you longer life, better life, and more freedom, and the details are there. And if you compare within transplant, there are different types of transplant. The two fundamentally different groups are living donor transplant and deceased donor transplant. And we think that from our medical perspective, living donor transplant is the best treatment. It's better than deceased donor transplant for many reasons. One important reason is that you don't have to wait for deceased donor transplant. We will talk about that. You sometimes need to wait 2 to 8 years on dialysis, whereas you can get a living donor transplant within a year. These kidneys are stronger. They usually work faster and last longer. Importantly, however, if you want a living donor transplant, the patient or the family will need to find a donor. If you're waiting for a deceased donor transplant, Trillium Gift of Life Network, that's the organization that works to find deceased donors and work up those deceased donors. If you want a living donor, the patient and the family will need to find a donor and bring it to the healthcare system. So these are the advantages: shorter waiting time, longer life, and better function. So importantly, to emphasize repeatedly, if you can have a living donor transplant, that's the best treatment for kidney failure, better than deceased donor transplant and better than dialysis. However, if you want a transplant, it's a long journey. You need to learn about transplant. There's a lot of testing involved. We'll talk about that. And then even after you get cleared for transplant or get on the waiting list, there are tests to be repeated, and it takes time and it's an effort. So especially if you want a living donor transplant, then you need to somehow find people who are interested in potentially donating to you. And very, very frequently, it feels like that this photo shows that you're alone on that journey. And sometimes people don't want to share that they have a kidney disease, and they're kind of hiding that. And that makes them even more alone and lonely in this very difficult and challenging journey. Whereas it's better if there's a team working with you. If you have kidney failure, if you want a transplant, and especially if you wanted a living donor transplant, yes, the medical team is there, but as Nick also pointed out, you are in control, you are in charge of your own life and health to some degree, and it's important to take that initiative, but also it's important to kind of recruit a team who can help you with different tasks that are involved in finding a donor and finding a matching kidney donor and eventually get a living donor transplant. So team is important both before and after a kidney transplant, and support from family and from the community. And these are just some tips about how to potentially find that donor if it's not immediately available. There are a number of sites on the internet I will show you at the end where you can find more information, but it does require some thinking, some working on it, and potentially, as I mentioned, finding people who can work for you, because it's not easy to ask anyone to potentially consider a donation. It's easier if your friends, if your family, if your parents, if your spouse will do that work, at least in part, for you. It's important also to kind of create lists for potential people who might consider this donation, this generous act. And sometimes donors come from not from your inner circle or from your family, sometimes because what Dr. Suneja mentioned, that the family members may have the same condition that you have and they may not be medically eligible. And sometimes there are surprises. People whom you don't know too well or not even know at all would consider, especially if you're able and willing to go to share this information broadly, potentially using the media, social media, internet channels to share your story. And briefly, who can be a living donor? Anyone can be a living donor who is healthy enough. There are some conditions, but I usually suggest to leave it to the medical team to determine if someone is not medically eligible for donation. Anyone who wants to consider it should come forward and should contact the transplant center on behalf of their potential candidate. And just very briefly about the donor surgery. And of course, again, if you're wanting to do a donation, if you want to donate your kidney to someone whom you love or whom you know well, you need to undergo a surgery, which does carry some risks, but it's important to know that nothing in life is without a risk, and we do many risky behaviors that are much more risky than donating a kidney. if you donate a kidney, usually it's done laparoscopically. Very small scars, very small wounds are being made. The surgery itself takes a few hours, but usually you are out of the hospital in 2-3 days, and you will recover in 1 to 2 months and can get back to work within that period of time. So it is important to know that this is something, an inconvenience, it's a surgery, but it does give a life, another chance for the person who has a kidney failure. If the living donor is not a match, which happens, there is a national program which is called the Kidney Pair Exchange Program, where they can, through computer technology, they can find a matching donor. If you have a donor, a living donor who is cleared and it's not a match, both you and your donor will go into this database, and then the database mixes and matches donors and the recipients. So your donor will donate their kidney to someone else, and someone else's donor will donate to you. More than 1,000 transplants have been done through this system over the last 10 years or so in Canada, and similar systems work many other places. What is the process? As I mentioned, it's quite tedious. There's a number of blood tests and x-rays and other testing and consults. You need to see specialists if you want to go to the transplant route. Most of these tests are done in the kidney clinic, in the multidisciplinary kidney clinic that Dr. Suneja mentioned, or in the dialysis unit. Once this package is done, then your package will be transferred to the transplant center, where specialists will see and assess whether you're a candidate. And this is way off this figure. What I wanted to use this figure for is to illustrate that once you went through all the testing, which could take up to a year or two, actually, and you're cleared for transplant, you can get a living donor transplant within a few months, or you will be placed on the waiting list, which could be as long as up to 6 to 8 years of waiting. And why is it important? And again, why is it important in the context of a South Asian audience? The waiting time depends on blood group. This figure illustrates that blood group B and to some extent O is the longest waiting time. And blood group B is more frequent in patients who come from South Asia. And what it means is that if you don't have enough donation from within the community, there are less blood group B donors. And patients who are blood group B from this community, they will have to wait much longer for a deceased donor kidney. So that is a reason why we try to encourage both living and deceased donation, because there's not enough donor for anybody. On average, a little bit more than 1,000 transplants are being done, or 1,300 transplants are being done in Ontario. And, 100 patients are waiting for transplant, and it's only 500-700 transplants a year that are done. And of course, new patients are coming to the waiting list. So there is about 1,000 kidneys missing every year that could be donated, either deceased or living donation pathways. Trillium Gift of Life is the network that kind of organizes deceased donation. One person who is healthy enough, whose lungs and heart and liver and kidneys and pancreas can be donated, can save 8 lives. So it is quite a generous act. It's very strictly regulated. You cannot ask money or other payment for the donation, either deceased or living. Registering is easy online, or when you're renewing your driver's license or health card. And if a person gets into the hospital and they are dying, the team, the physicians, the ICUs will do everything they can to save that person's life. And only if that person is brain dead or they suffered irremediable damage, then they will become a potential donor candidate. Importantly, it's important to register as a donor, but be aware that the hospital will have to ask the family in every given case. And even if you're registered, if the family doesn't know that this is what you wanted, if they think that it's better not to donate, then they can deny that. So if you registered, if you want to donate after death, then you probably better to talk to the family so they know it makes their job easier when they need to decide on your behalf. Just putting this up again, whether transplantation costs money for the recipients or a living donor, there's a lot of coverage there that helps both the recipient and donor to have as little burden, financial burden as possible. We can talk about that later, and social workers will know even more than we do. What happens at around the time of the transplant surgery? So the recipient who's waiting for a deceased donor transplant may get called at any time during the day or night. And it's important that you have your cell phone around, because the coordinator will only try for an hour. If we cannot reach you within that hour, then we need to go to the next person on the waiting list. So once you come to the hospital, sometimes what happens is that you come in, and by the time you arrive, the organ is not here. But when the kidney arrives, we realize that the kidney is not good. And so sometimes patients will go home without a transplant once or twice before they get their real call. The surgery is about 3 hours long. And if everything went well, then the hospital stay is about 4 to 6 days long. And about 95% of all the kidneys that we transplant will work in the first year at least. And so it's a very successful procedure. After the transplant, in the first period, you will be very busy. You will have to come to the hospital 2-3 times a week. Sometimes you need to come back to the hospital to be admitted, but eventually everything settles down, and people are usually able to return to work after 2-3 months after the surgery. At about a year after transplant, patients who are stable do blood work every 3 months, and then come to the clinic every 6 to 12 months. So compared to that, to the dialysis frequency, where you either need to do every day peritoneal dialysis, or you need to go do hemodialysis in the hospital or at home at least 3 times a week. So it's a way better life, and that is one of the big advantage. And some of the places where you can get more information, Explore Transplant Ontario, it's a large information for transplant-related information. There is a volunteer organization called Transplant Ambassador Program. These are patients who had a transplant or living donors who donated their kidney or mainly kidney, and they are volunteering to help patients and donor candidates to understand what is it like to live with a kidney, or what is it like to donate a kidney. So you can hear it from people who went through it and not from the doctor or from the nurse. The Center for Living Organ Donation that organized this event also has a lot of information on their website, but also it organizes events where we train people how to potentially ask for donors. And there's a lot of activities. Again, I suggest that this could be visited. And these key messages will be there. I don't want to read them. The bottom line is that the transplant is better than dialysis. Living donor transplant is the best treatment for many patients, but dialysis is importantly a life-saving treatment as well. So people who cannot have a transplant, dialysis will have them live and have them live a meaningful life as well, as much as they can with their condition. So it is important to keep that in mind as well. And some people will decide to stay on dialysis because they don't, for this reason or other, they don't want to have a transplant, or they cannot have a transplant. Thank you very much. I hope that there will be questions both about transplant and dialysis. Thank you again for your attention.
Thank you, Dr. Sumeet and Istvan. Thank you very much. If we can now have questions, please go ahead and ask your questions to both doctors, and they will be happy to answer some of the questions. And the first question that I have is, have you seen, since you have been doing this outreach, have you seen any change in the terms, in the numbers of South Asians having more dialysis and transplant than before, or we are still lagging behind in terms of numbers?
Thank you very much. There obviously it's difficult to answer because we had COVID in the meanwhile. So this whole initiative started 5-6 years ago. There has been an increase in living donation in general. Of course, with COVID and the difficulties what this caused, it's difficult to know how much is the real change. But unfortunately, it seems that the differences between both living donation and deceased donation between the white population and different racialized communities is still there to a large extent.
Thank you, Farhana, and then after Farhana, Jasdeep.
Thank you so much, both doctors, for your wonderful presentation. So I have one question just came to my mind. So we heard that every kind of organ transplantation might have a rejection rate from the recipient's end, right? So we may transplant one organ, but the body might reject that organ. So what is the rejection rate for kidney transplantation? That's one question. And another question is, it's kind of like a scenario. So if a loved one from the family member, they donated kidney to the other family member, and the family and the kidney recipient, he rejected, his body does not allow the organ. So what is the process then? So like the kidney can be retransplanted to the donor or not?
Sumeet, do you want to go or?
Sure. So in terms of retransplantation is impossible. So usually now with the screening strategies we have, the acute rejection rates are much lower. Right. So there's a lot of good screening that happens before. Chronic rejection that happens over time. That risk is there over the years, but acute rejection rates are much lower than previous. And in terms of like once the kidney is donated and out of the donor's body, it cannot be replanted. So that's if the kidney does have an acute rejection, that's a loss, unfortunately.
Yeah, just wanted to add that a rejection doesn't necessarily mean that the kidney is lost completely. The rejection is a process, as Sumeet mentioned, that sometimes it takes years. And if we detect that early enough, some intervention can be done. So we can change medication or increase the anti-rejection medication so that kidney can work for some time. At our center, the rejection rate for living donor transplant is around 5-7%, and deceased donor transplant, it's around 10%. So it's not too high, 1 in 10, 1 in 20.
Okay, yeah, thank you so much. Thank you for the answer.
Jasdeep, go ahead, please.
Thank you. Thank you both the doctors for such a great presentation. I have worked with these patients when I was working as a social worker in a hospital back home in India, where I was also gaining experience in different departments, and dialysis happened to be one of them. And I was just very curious to know, like, why do South Asian communities have, or is it only the South Asian communities who have a higher rate of dialysis cases in them? And is it that the men tend to have more than the women? And secondly, is the donation for dialysis patients open for a certain category of people, or it could be any family or anyone from outside?
Okay, so South Asians do have a higher risk. So it's a complex interplay of a lot of things. Like we discussed, there is high risk of diabetes prevalence, there's obesity, there's insulin resistance, there's hypertension, and then there's genetic predisposition. So patients who are South Asians do progress faster in terms of their kidney disease, so compared to the Caucasian counterparts. In terms of the second question you had was with regard to the donation. So it doesn't have to be related. It can be a friend, it can be anyone who can come forward as a kidney donor. It doesn't even have to be same blood group like Dr. Mucsi discussed, right? You can have paired exchange program, you can have ABO incompatible, different blood groups. That transplant process can still.
So the bottom line being that we have to be, as South Asian, we have to be careful about the blood. The sugar content in the blood is one of the factors for us to be looking in depth.
Absolutely. So having worked in Brampton and dealing with a lot of South Asian patients, diabetes is one of the big things, right? A lot of patients do not take care of their diabetes as well as they should. So you look at their hemoglobin A1C over the years, and it's running 9%, 8%, and it's asymptomatic. They don't feel anything. and slowly and steadily it's causing damage to the kidneys. So a patient who is overweight, even obesity in itself is a high risk factor for kidney disease. Even patients who have borderline diabetes, 17% of them can develop kidney disease. So it's very, very important. This metabolic syndrome with obesity and blood pressure and diabetes, and especially abdominal obesity that creates insulin resistance, is very high risk for kidney disease. Absolutely.
That's so great to know. So one has to be very careful in getting your blood sugar tested. And how often should we do it, say, in a year's time, in a 1 year period?
I think for a normal healthy person, once a year annual physical with your sugar checkup and your kidney function test and urinalysis is the way to go. And then depending on your results, if you do have, any issues, then the frequency will change accordingly.
Thank you, Doctor. Thank you, Dr. Sumeet, so much. Welcome.
Dr. Sumeet, are South Asian men more at risk than South Asian women?
So I think in general, it was thought that, men for heart disease, you see a lot of high incidence of coronary artery disease, especially in South Asian men. So there is, higher inflammation, higher atherosclerotic disease, or blockage, and they're presenting a lot earlier. So we see that more in South Asian men compared to women. Estrogen can be protective in terms of heart disease. And with regard to kidney disease, eventually, I think the statistics kind of level off, it ends up being equivalent once you get down to chronic kidney disease level. But definitely we're seeing a lot more, early myocardial infarction in men and a lot younger and more aggressive heart disease. Absolutely.
Dr. Sumeet, I have one question which just struck me now. What's the age group are we looking into where we should be more careful of? From what age onward should we be more careful stressing on the blood sugar and likely to get kidney problems?
So I think if you're a healthy weight, you're probably good. You don't have to worry. But once you're getting to, you're getting after 40, I think you should, make sure that you have your annual physicals done.
Thank you so much, Dr. Sumeet.
So Dr. Sumeet and Dr. Istvan, we have a diabetes education program that Ansjot and Rajat are leading, and we are organizing clinics, we are doing checks, we are educating. And the question is for Ansjot and Rajat, do you guys see that we should include some of the slides that Dr. Sumeet and Istvan have presented showing that South Asians are more at risk, or do you already have those slides built in your education program?
So just to mention that we are running a diabetes education program over here at PCHS, that too in Punjabi and Hindi, the South Asian languages. So in order to address the steep increase of diabetes cases within Peel region that we have seen in the research done by PCHS in the past years of 2015 and 2016. And this education program is done under 4-week module program where we are doing 1-hour sessions in every week. So one of our last sessions, which is taken up by our nurse practitioners, is based on diagnostic testing and various complications surrounding management and complications surrounding diabetes. So in those complications, we do touch about different kind of organs that are being affected apart from kidneys too. But after viewing your presentations, which is completely detailed over CKD, I think it would be very useful for us to incorporate some of the material surrounding kidney disorders related to diabetes and how we can prevent them. And it would help us design more effective strategies around how to educate clients around prevention of kidney disorders.
And just coming back to your point. So, another thing that we often see is this fear of medication in our community, right? They don't want to take medication. Once they start the medication, it might include my mom too. So once you start the medication, you'll have to take it for the rest of your life. And this fear of taking medications, and also always looking at natural alternatives. I mean, I'm not against natural alternatives at all, but they have to go hand in hand with, the normal standard of care treatment for patients. So I just recently came back from India, went there for a wedding, and there was this big billboard and it said, stop dialysis, take Ayurvedic medicine. I was like humongous in like Connaught Place, which is like in Delhi, right? It's like, how misleading is that? You're asking patients to stop dialysis and take Ayurvedic medicine, they're going to die of hyperkalemia or hyperpotassium.
Yeah. No, I get you, Dr. Sumeet, from where you're coming.
So
Just to add on.
Go ahead, Rajat. Go ahead. No, go ahead.
Just to add on to her point, this is the same. We are having the same response from the community when we go out, specifically while discussing about diabetes. So the equity-based challenges that we see are mostly related to the language barrier that clients have while going to physician offices within Peel region. Asking the right question from your healthcare provider is one of the biggest challenges, and that is limiting the trust that they develop with the current medical and healthcare practices of modern facilities. So is there any input that you would like to give us as a social healthcare organization, how to address these challenges, how to develop more trust among the community with the treatment surrounding modern healthcare?
So I just heard the last bit of the question. Rajat, would you mind please just give me a snapshot again?
Yeah, so what I was saying was there are many equity-based challenges when we address people concerns specifically surrounding chronic diseases and which are related to metabolic disorders like diabetes, obesity, and the biggest barrier that we have realized through our education programs is language barrier plus asking the right questions from your healthcare providers. Like initially, like people who are most of the immigrants that are coming from different South Asian countries belong to those countries where healthcare is more privatized. So they usually jump from one doctor to the other, depending upon what kind of treatment suits them the best. But that kind of facility is completely not absent from a social healthcare system, because of which they are less, they get mistrusted with the current healthcare practices, and they jump onto alternative medications rather than trusting current healthcare provisions. So is there any kind of input that you would like to give from your side, how to develop more trust with the clients and what kind of, how to address such kind of challenges?
Sure, no, that's a great question. So, I often in my clinic, I will educate people about the medications I'm giving them. So I will explain to them, I'll take the time to discuss, show them their blood work on the screen and discuss some pathophysiology of their disease and explain how the medication works. And I find they're more likely to take the medication if they know exactly what they are getting it for, because a lot of times we physicians are so rushed. We have so many patients to see, and especially family physicians, they take the brunt load of this stuff, and often they don't have that much time to spend with patients. So I find like that way, like maybe more time with patients and maybe creating more educational videos, or so people can, you can give them a link if you don't have time and for them to go to and refer it to. And then showing them, when they come back, showing them like how their blood work is improving and how the medications are working, and can also be beneficial.
Yeah, I would like to add a couple of things maybe there. One thing is that I think it is important what you said in your question, that I think your role as a community organization is probably could be manifold. One is to try to inform patients what are the right questions that they want to ask from their doctors or nurses when they see them, equip them with that knowledge and encourage them to ask those questions. So if you have diabetes, or if someone in the family has diabetes, when they go to see their doctor, they should ask for blood test or urine test with that frequency, with once or twice a year, depending where they are. But they should be asking for that and have that, initiate that discussion what Dr. Suneja started. The other thing is to advise them, especially if they are more seniors and less fluent in English, to have someone going with them from the family who can both ask those questions but also take notes on their behalf. So it's always good to have that support. And finally, which I think is potentially a useful solution as well, if you yourself as an agency can kind of create a bit of a navigator system when you can also accompany patients who require that additional support to their visits with their healthcare providers. I think it would probably be helpful if, and then you as a trusted organization in that community could kind of help to bridge that gap between patients and the healthcare system.
Aditi, you wanted to ask a question?
Yes, thank you. I wanted to find out, if genetics has something to do. So if I've had two family members, suffering or passed away from CKD, what should be the frequency of the other family members to get tested, or how likely are we to get it? Or, what are some very early warning signs that we can maybe tell at home, even without visiting a doctor? Because I feel our body shows us signs much before,
So there are different kinds of kidney disease that run in the family. So it really depends, what your family member has had. If they've had something called polycystic kidney disease, then, you should get an ultrasound done and blood work done and a urinalysis done, right? So the rest of the diseases, there are other things like glomerulonephritis, like there's things called IgA nephritis, and FSGS can have a genetic component. Again, all kidney disease is detected by blood work and a urine test. You are not going to have any symptoms if you have any abnormality in the early stages, right? Unless there can be some blood in your urine from other reasons. So it really depends on the type of kidney disease. So discuss that with your physician and they'll guide you better in terms of the frequency.
Okay, anybody else that has a question? And I know that we are about 15 minutes over, but that's fine. I think it was very valuable session, and we are my suggestion to you would be in your discussions with your clients, and especially from the South Asian community, but that doesn't mean South Asian community, anyone, and if they have diabetes and if they are new to Canada, please encourage them to make a family physician, go for regular checkups, talk about these things, because what the Dr. Sumeet's one thing that we have 3 times more cases now. The people with diabetes, with kidney disease are increasing. It's a burden on the healthcare system and all that other stuff. But I'm also worried about the suffering that goes with it and the challenges of lifestyle, not just the economic part, but also the kind of cost, other costs as well. So I would strongly encourage all our social workers to please start talking, making a habit of just asking them, do you have a family physician? Are you regularly going for checkups? Can you please make sure that you do this? If you have any family member that had such a illness, please go and see your family physician and get some regular checkups. That's what I got out of today's session. And my sincere thanks to Paula, Istvan, and Dr. Sumeet for sharing this. You will be getting the PowerPoint presentations. Maybe we can take a look at our diabetes education program. How do we incorporate more? And if you have any other questions that our clients may want to have, or if we want to bring Dr. Sumeet and Dr. Istvan back again to do a session with the whole community, the more we can raise some awareness, the better it is for. And so if you want to make some closing remarks, or Dr. Sumeet and Istvan, that will be fine.
Yes, thank you. Thank you so much, everyone. And, I'll leave that with the one last note. Thank you for all the great work you're doing out in the community. I think it's so important, and, educating people and raising awareness. And, diabetic kidney disease is preventable. It really is. Like, we are using so many new medications now, which are really game changer in treatment of diabetic kidney disease. They give people 18 years or more kidney life. So taking charge of your health, being empowered yourself and taking control is the key to conquering this epidemic. Thank you.
Thank you as well. And let us know if there's any question, and hope to see you soon.